Hi guys, today the lecture is about surgical anatomy of the malleolus. We are gonna start from anatomy overview. The bones which help for formation of ankle joints are tibia, fibula, talus, calcaneus, navicular, cuboid, first and second cuneiform. The ankle joint is where the tibia, fibula, and talus joint provide mainly plantar flexion and dorsiflexion of the foot. Subtalar joint is the articulation of the talus and the calcaneus, responsible for inversion and eversion of the foot. Both joints are synovial, which means they are surrounded by a capsule and supported by ligaments. The ankle joint is supported on the medial side by the large and strong deltoid ligament. On the lateral side, the joint is supported by the anterior talofibular, the posterior talofibular, and the calcaneofibular ligament. The ligaments are not as large or strong as the deltoid ligaments. Additional lateral stability for the ankle joint is provided by the length of the fibula and the lateral side of the ankle. The ankle joint is strongest when placed in dorsiflexion. The talus fits match tire between the tibia and fibula in this position. Joint is weakest when placed in plantar flexion. Joints, ligaments, and muscles help to create and maintain the two basic arcs in the foot. Longitudinal arc has medial lateral deviations. Transverse arc runs from side to side. These arcs assist the foot as shock absorbers, also provide propulsion of surface during movement. Muscles are divided into anterior, posterior, and lateral compartments. Muscles of the anterior compartment essentially produce dorsiflexion and extension of the toes. Tibialis anterior, extensor digitorum longus, extensor hallucis longus, and pronaris tertius. Very compact area with little room for any extra tissue or fluid. Posterior compartment mainly function to produce plantar flexion of the foot, referred to as the calf muscles, is divided into two compartments, superficial section and deep section. First, superficial section. Gastrocnemius, soleus, and plantar muscles. Gastrocnemius and soleus attach on the calcaneus via the Achilles tendon. Plantar muscle is small and insignificant in action. The second one, deep section of this compartment, the tibialis posterior, flexor digitorum longus, flexor hallucis longus, and popliteus muscles. Beside the popliteus, these muscles course behind the medial malleolus of the tibia and along the bottom of the foot. They help with the plantar flexion as well as flexion of the thighs. The popliteus muscle is important in knee flexion. Lateral compartment of the lower leg contains the peroneus longus and peroneus brevis muscles, mainly elevators to turn the foot outward of the foot, but do assist with simple plantar flexion. Both of these muscles course behind the lateral malleolus of the fibula. Peroneus longus courses under the lateral side of the foot and runs across the bottom to the first metatarsal and cuneiform bones. The peroneus brevis attaches at the base of the fifth metatarsal and is subject to evolution, forcible tearing away or separation. Now we are going to topographical anatomy of the ankle joint. Border. Superiorly, we can imagine a circular line across the base of ankle. Inferiorly, we can imagine oblique line across upper part of ankle sole. Dorsum of foot. External orientation angle, lateral below medial on 1.5 to 2 centimeters, tendon of extensor peroneal muscles. Projection, we can see artery and vein dorsalis pedia, nervus peroneus profundus, line from medial between ankle to first interphalangeal space. Artery tibialis posterior, nervus tibialis behind medial ankle on 2 centimeters. Venus siphana parva, nervus surrealis, line from medial distance between lateral ankle to Achilles tendon to tuberosity of fifth metatarsal bone. Vein siphana magna, nervus siphaneus, anterior surface of Malleolus. Superficial formation. We can see skin with sotain, except in region of Achilles tendon heel. Subcutaneous tissue developed on site from Achilles tendon, almost absent above ankle. Superficial fascia in appearance of thick sheet. Venus saphena magna, nervus siphaneus in front from medial ankle on 1 centimeter. Venus saphena parva, nervus suralis behind from lateral ankle. Now we are seeing the proper fascia. It's a thickened in front in retinaculum musculus extensorum, from which enters septum deep down, formed osteofibrous canal for tendons of extensor muscles. Behind, there is 2 sheet formed for Achilles tendon. Lateral, there is retinaculum musculus peroneum or fibularium, superior et inferior, from which enters septum to bone, formed osteofibrous canal for tendon of peroneal muscles. Medial, we can see retinaculum musculus flexorum, which together with medial ankle and Malleolus canal. Neurovascular bundles. There is artery vein tibialis anterioris, in region of ankle joint, anterior vein dorsalis pedis, nervus peroneus profundus goes in osteofibrous canal together with musculus extensor hallucis longus. Artery tibialis posterior, nervus tibialis goes into venalis malleolaris posterior from tendon of flexor. Where divides correspond on artery nerve plantaris medialis, medialis et lateralis. Above ankle artery goes branches artery calcanea. Lymph nodes are there absent. Lymph flows to popliteal and inguinal lymphatic nodes. Collateral blood supplies. Red calcaneum formed anastomose with artery peronea tibialis posterior e anterior. We have complication by the name of ankle sprains. A sprained ankle is an injury that occurs when you roll, twist, or turn your ankle in an awkward way. This can stretch or tear the tissue that help to hold your ankle bones together. We have 2 kinds of ankle sprains, one inversion and another one eversion. The inversion sprain, which mostly occurs in anterior talofibular ligaments. For stretch or tear of calcaneofibular and posterior talofibular ligaments, there is need of more forced inversion needed. And eversion sprains, they are rare, evolution fracture, and heal slowly. The sign and symptoms: pain, inflammation, discoloration, instability of joint. And how we can see the patient with the ankle sprain. We have abbreviation of hopes, which first of all we have to take a story and ask from the patient what happened. Second, observation. The third, palpation. And fourth, special tests like anterior drawer test, bump test, Taylor tittle test, functional examination. Treatment for ankle sprain: RICE, which stand for raised ice compression and elevation, preventing equipment and tapping. Although there's other ankle joint injuries such as Achilles tendonitis, shin splenitis, that we need to know what is it and what's the cause of these injury, and what's the symptoms and treatments. And these are the links that I use for making this presentation. Thank you for watching.